Good morning, students. Today we will see about the phototherapy. As, as we talked in the with exchange transfusion, this topic is already covered in your third year curriculum, but we will just have a revision of the phototherapy. Bilirubin metabolism. Bilirubin is a pigment product of the heme degradation pathway. Bilirubin is in two forms, unconjugated and conjugated forms, depending its on solubility in the plasma. Unconjugated bilirubin produced in the reticuloendothelial system is a lipid soluble and transported to the liver by binding with albumin. In the liver, hepatocytes, the unconjugated form bilirubin conjugates the glucuronic acid and known as the conjugated form. It is a soluble form of plasma. The conjugated bilirubin is secreted into the bile and later into the gut. Some of the conjugated bilirubin reabsorbed in the circulation as unconjugated bilirubin, the process of recycling bilirubin, known as enterohepatic circulation. Jaundice in the newborn's fetal hemoglobin is replaced by adult hemoglobin. Hence, the red blood cells of hemolysis occurs, more bilirubin formation occur higher rate in them. This results in both unconjugated and conjugated forms of bilirubin. Indeed, the immaturity of hepatic metabolic pathway too leads to the increased level of bilirubin. As such, neonates are more prone to get hyperbilirubinemia condition. Neonatal jaundice can be either physiological or pathological. The physiological jaundice occurs in the first week of life, usually within first two to 5 days after delivery. Also, this returns back to normal within 10 to 14 days after birth. If the signs of jaundice appear within 48 hours after birth, it is due to pathological reasons and it is pathological jaundice. One severe complication of neonatal jaundice is the chronic thirst. When the blood unconjugated bilirubin elevated in the blood, those bilirubin molecules can cross the immature neonatal blood-brain barrier and get deposited in the basal ganglia. This causes irreversible damage to the brain tissue, causing chronic thirst. Therefore, it is important to treat this neonatal hyperbilirubinemia before complication takes place. Phototherapy is as a treatment of choice. Phototherapy is the treatment of choice of most clinicians and detected as jaundice in the neonate when the serum bilirubin level is more than 5 mg per deciliter. When this level is raised above the required level according to the days of life, the neonate is prescribed for phototherapy treatment along with breastfeeding. External transfusion is another treatment option if the phototherapy is ineffective in severe cases. Phototherapy is used since 1958 for the treatment of neonatal hyperbilirubinemia. It causes unconjugated bilirubin to be mobilized from the skin by structural isomerization to a water-soluble form, that is lumirubin, that can be excreted in the urine. The aim of phototherapy is to decrease the level of unconjugated bilirubin in order to prevent acute bilirubin encephalopathy, hearing loss, and chronic thirst. Lamps emitting light between wavelengths of 400 to 500 nanometers are specifically used for administering phototherapy as bilirubin absorbs this wavelength of light. The light is visible blue light and contains no ultraviolet light. Phototherapy is the way of treating jaundice. Special lights help break down the bilirubin in the baby's skin so that it can be removed from his or her body. This lowers the bilirubin level in the baby's blood. Phototherapy treatment using fluorescent light containing a high output of blue light to reduce the amount of unconjugated bilirubin in the skin of a mildly jaundiced neonate. Indications: phototherapy should be used when the level of bilirubin is hazardous to the infant if it were to increase even though it has not reached the level of requiring external transfusion. Prophylactic phototherapy may be indicated in the special circumstances such as extremely low birth weight infants or severely bruised infants. In hemolytic disease of newborn, phototherapy is started immediately while the rise of bilirubin is plotted. Prophylactic phototherapy may indicate in circumstances like extremely low birth weight or severely bruised infants. Phototherapy is usually contraindicated in the infants with direct hyperbilirubinemia caused by the liver disease or obstructive jaundice because indirect bilirubin levels are not usually high in these conditions and because phototherapy may lead to Brown's baby syndrome. If both direct and indirect bilirubin are high, external transfusion is probably safer than phototherapy because it is not known whether the Brown's pigment is toxic. Mechanism of action: some bilirubin are present in the interstitial spaces and superficial capillaries of the skin cutaneous tissues. During the phototherapy, these molecules are exposed to light. The photons of energy are absorbed by the pigment down in bilirubin. This leads to a sequence of photochemical reactions, configurational isomerization, structural isomerization, photooxidation. This energy converts bilirubin into non-toxic isomers such as protobilirubin, lumirubin, which are more polar and thus water-soluble. These photoisomers can be eliminated from the body more easily without undergoing the process of conjugation in the liver. Indeed, since they are water-soluble, transporter proteins are not required. But the photobilirubin is reversible to native bilirubin while lumirubin is irreversible. Hence, the former isomer can enter enterohepatic circulation and less amount is excreted. As formation of lumirubin rate is limiting step, less amount of lumirubin is formed. But it is cleared from body more effectively. Excretion of bilirubin isomers from the body, especially lumirubin, declines the elevated serum bilirubin and thus reduces the risk of cardiac arrest. Technique. Bilirubin absorbs light maximally in the blue light ranges 420 to 500 nanometer wavelength. Daylight and cool white lamps have a spectral peak between 550 to 600 nanometer and less effective than special blue lamps, which are of average 420 to 480 nanometer. But blue lamps interfere with observation of the skin color in the body and cause headache and nausea to the caregivers. Hence, a combination of white and blue lamps is preferred. A unit of 4 special blue and daylight lines will give an effective radiance. There may be single phototherapy, double phototherapy, triple light phototherapy. The distance of the baby from the light source affects the effectiveness. Typically, the distance is 45 cm is used. Nursing gear. Keep the baby naked except for diapers as large surface area exposed. More effective is the phototherapy. Like the eyes must be shielded to prevent potential adverse effects on the retina. Closely monitor the temperature for hypo or hypothermia. Maintaining baby in a flexed position with rolled blankets along the sides to help to maintain heat and provide comfort. Oily lubricant should be avoided to prevent tanning or frying effect. Accurate charting include times of phototherapy started and stopped, proper shielding of the eyes, type of fluorescent lamp, number of lamps, distance between surface lamp and the infant, use of phototherapy in combination with the incubator or bassinet, photometer measuring the light intensity, occurrence of side effect. Complications usually include increase in environment and body's temperature, increase in insensible water loss, especially in premature infants. Stools tend to be loose and more frequent. This loss must be compensated by increasing fluid intake by 25%. Monitor temperature frequently and check weight twice daily. Retinal damage. Retinal degeneration may occur several days after continuous exposure. Bronze baby syndrome. Skin, urine and serum become brownish black after several days of phototherapy. Seen most often in babies with conjugated hyperbilirubinemia. Babies recover fully several days after phototherapy is discontinued. Electrolyte imbalance such as hypocalcemia, transient skin rashes may occur, drying of the skin which can lead to excoriation and breakdown. Others include electric shock and unproven potential effect on endocrine and sexual maturation. Fibro-optic lights can also use in the phototherapeutic unit. Advantage, low risk for overheating the infant. No need for eye shield. Able to deliver the phototherapy with the infant in the bassinet next to the mother's bed. Simple deployment for the home phototherapy. Possibility of irradiating large surface area when they combine with conventional overhead phototherapy units. Drawbacks may include noise from the fan in the light source, decrease of delivered energy with an aging and break of the optic fibers. Some of the new fiber optic units are now incorporate photodiodes as the light source. Light emitting diode or LED lights are found in the most newer phototherapy units. Advantages include lower power consumption, low heat production and much longer lifespan of the light emitting units comparing with the older light sources. Thank you. Thank you for listening. If you have any comments, please let me know.